Welcome to the campus of North Idaho College and today's broadcast of the North Idaho College Public Forum. The crew is comprised of North Idaho College television students. Your moderator is North Idaho College political scientist, Tony Stewart.
Today we wish to start a 2-week series on a topic that we have never covered on this program, but we're very happy to correct that problem and to bring it to you. Our subject is speech therapy, in fact speech problems, and then speech therapy and how to deal with it. On program number 1 we shall discuss the issue of identifying the problems of speech, and on program number 2 next week we'll deal with speech therapy. In order to accomplish our goal of discussing this very, very important topic that many of you have experienced in your families and in your livelihood, we're happy to welcome to the program Lola Hagedorn. I'm particularly happy to welcome her to our program not only because of the important topic, but because she's a very old friend that I've known many years and I enjoy being with her. Our guest has a BA degree and a master's both from Eastern Washington University in speech pathology and audiology. She has also done doctorate work, or work toward her doctorate degree in early education and administration from the University of Idaho. Lola, it is a very special privilege to have you with me today, and I look forward to discussing this very important topic.
Thank you, Tony. I'm looking forward to it also.
As I indicated to our viewers, on program number 1, we would like to deal with the question of speech problems and identifying those in particular. I think, however, it would be very comfortable to our viewers if we started by trying to define the field of speech therapy. It's my understanding it is a new field. And would you take a few minutes to talk about the history of the field and where it has come from and where you see it going in the future?
Thank you, Tony. The study of speech pathology and audiology is a fairly new field, and it has only actually been defined as definitive as it is at the present time within the last 10 or 15 years. We experienced it during both the end of the First World War and then into the Second World War. We were having a lot of young men come back from war experiences with a lot of very severe traumas and brain damage. And the medical field began to look into why this was occurring and what could be done to correct it. Also at the same time, which I think most of our audiences are very aware of, that the medical field and the technology has become so sophisticated and so advanced that children were living, that the mortality rate has gone down significantly. People are living longer. Because of that, we're experiencing that we need to deal with older people who have strokes. A lot more children are born that have handicaps and defects that at one time would have died. Mm-hmm. And so the need came to not only to identify these problems, but also how do we remediate them once we see them. With the young men that were coming back, we were realizing that they had broken and many times some expressive speech, and we're not realizing that these men were not understanding as much as they possibly could have.
So we're really dealing with a problem that covers all age groups for different reasons. Mm-hmm. Children have certain problems, and people, as you've indicated, older that have experienced certain things have problems.
Right.
Lola, it's my understanding that in dealing with this new field as it's evolved, we're talking really in 2 parts. First of all is an academic question that you prepare people to deal with the problem. And maybe we can discuss a little bit about the academic field. And then secondly, once prepared, there is the clinical work. So can we just briefly talk about the 2?
Right. When you prepare to go into the field of speech pathology, which I think is really to a student's benefit in the respect that many times people do not have any clinical experience before they enter their field. Mm-hmm. And within our setting, we do both our academic work and our clinical work hand in hand. So you will take your classwork during the day, but you clock so many clinical hours. So even when you complete your bachelor's degree, you have clocked a very large amount of hours working with all the different handicapped individuals that you will deal with within your profession. And many times I know with my friends who are in education, their first experience with children are when they do their student teaching, where we have already clocked many, many hours in regard to working with youngsters before we are actually placed in a classroom setting.
And that's continued through the graduate program too, and so forth. Very good. I just want to get that brief background for our viewers who would not have the experience possibly with it. I think that what we need to spend the 20-some minutes we have left together is identifying and classifying certain types of speech problems, and language problems maybe is a better term to use. If I may, I would like to go somewhat through a list, and I will talk about a given problem as you've been so kind over the years to inform me about, and then I've observed too, and then you describe the problem and how we identify it. The first one that we hear so much about is lisping as a problem. Could you tell us, does that start early, and what is it, and how do you find out if that is the given problem a person has?
Okay. Lisping is what we would consider a speech therapy problem, and it can originate very early where a child begins to lisp, and then it can continue on into their early academic years and then on into adulthood if it is not corrected. Many times it will correct just on its own through maturation. It's a very small part of what we actually do. When we talk about speech pathology, we're really looking at just a small portion of what our total job involves. We look at language and its speech and hearing and voice. And lisping is just a very small part of that.
Mm-hmm. Maybe we should back up as we deal with that, and I'm going to give you some examples in a moment. But you're talking about pathology and language and all. We may have not clarified for the viewers that we are talking about some specific areas, and we'll do that, and then we will identify these under the area that it goes.
Right. If I may, Tony, might I just set a little bit of a background, and then we can go into each of the individual disorders, because your question you asked me is really interesting in the respect that when I asked individual people, what do you think a speech therapist does? Typically, that would be their response. They work with people who lisp, someone who mispronounces a sound incorrectly. But what we really do is we look at language as an all-encompassing problem, and that involves the way a person communicates, what they understand, what they express. And the lisping aspect is just the speech sound itself and how the sound is produced. And the same way with hearing, we look at hearing and at voice disorders.
Okay, so you're talking about those are really three different areas.
Three very distinct different areas that we define and look at individually.
Someone who is in the field, do they tend to specialize only in one of those, or once you're trained, you will work with all three areas?
We will work with all three. When you come out with your bachelor's degree in speech pathology, you are at that time a generalist. And as you begin to have your experiences, then you begin to specialize. Some people will begin to do and work mostly with adults, others with youngsters, preschool youngsters, some within a public school setting. And yet all of these things can be dealt with in different areas. A lisper, I would say, would typically be seen by a public school therapist.
Yes. You're a little bit like a lawyer in that you generalize, and then over the years you develop expertise. Again, I have before me a list of several things that are problems that speech therapy deals with. But as we go through this, I think it might be very helpful if you would talk about in a general way, and then I would invite you to give the examples of what we're talking about concerning language, or we're talking about concerning voice problems and so forth.
Okay.
Tell me a little bit more about what is the difference between the three as to a problem for a given individual, such as language versus the voice.
Okay. Okay. When we're talking about language, we're looking at a youngster or an adult and how they understand language and how they express it. And each one of us as individuals understand a lot more language than we're actually able to express. And as we begin to test with a little preschooler, we will have him do individual things like point to this, show me that, stand up, sit down, so that the child himself actually demonstrates to us that, yes, I am understanding what you say. I understand the language. And then you see what he can express. And we have lots of youngsters who will actually test to their age level as far as understanding language, but lack and do not have any expressive language. In the same way that carries on through to older people, or people who have been in traumas like severe car accidents, stroke patients who have developed and have a complete language system, but then through a trauma of some sort lose it. And we will do the same things with that type of a patient. We first of all see how much language does that person understand. Are they able to demonstrate that, yes, indeed, I hear what you're saying to me, but I'm not able to express that back.
You've brought a point to my mind, and I think that's what's good about the give and take. I'm gathering from what you're saying that for all of us, basically, at least in our country, that even the teaching of language with the family and in the school system and so forth, we have stressed teaching understanding of words, vocabulary, but we have not tested very much to see if in that understanding if they can then take it and explain it or share that with others. And so one of your jobs in your field is to develop the second part.
We develop both the receptive language and the expressive language, and even like an adult, you and I both have a much higher receptive language than we do an expressive language. And an example of that is when you're reading a book and you come across a word that you've never even seen before. Given that word in the context of the book, you pretty much can understand it. But if someone turned around and asked you what the meaning was, it would be much more difficult, because you do not have the same expressive language repertoire as you do receptive.
An example of this is in class with some of my students in political science. I will ask them what democracy is. They say, well, I know what it is. Well, tell me. And then it becomes difficult to
Much more
explain.
difficult.
Fine. So you have programs not only for young people or children, but that throughout life you can help people with the second part. Particularly. Give me some exercise examples of how you deal with older people on helping them to be more expressive in what they understand.
Okay, well, like when you look at an individual and it's a stroke patient or a trauma patient, it's very critical, again, that we look at the total individual, and you want to identify what his strengths and his weaknesses are. And if you can see that he does understand what you're presenting, then the most critical part that you want to do is to get them to express that, because then you have a foundation and a base, and as you begin to get them to express individual words, you want to build that so that they begin to have 2 words into 3 and 4 until you can get them into complete sentences. And you do the same thing like with a child also. You begin like with building blocks and building a tower. You get an individual word, then you add 2 words, and you begin to build so that you actually have more total communication. And this is the part that we were talking about, is the language aspect of our field. The next part, when you mentioned early, Tony, about lisping, that comes under what we would call speech therapy and speech development. And when we're talking about that, we're actually then talking about the child or individual has developed a language. They now have a language. They understand the language. They're expressing themselves, but you're looking at the way they're producing the sounds. And so now you're actually seeing how are they producing the sounds of the words that they're making, and that's where the lisp fits in. That is an error then that the individual is making within their sound system. And that is one that's within our field, very easy to correct. Many times parents will feel that particular problem is more serious than it is. And I think it's critical, and today as we talk, and I would like to stress that, and give people information on why it isn't a problem and how they can deal with that if it's in their own environment. Because so many times people, through being and trying to be conscientious parents, teachers, and individuals working with speech problem children, actually are doing a lot of things that are not helpful.
And we're going to really identify some of those, and then next week I'm sure people will tune in again to deal with the corrective processes, or what you often describe as remediation. You're really educating me too. This is not my field, and so I'm beginning to understand something that I have not in the past. We all attempt to use the English language, and we assume it's just a matter of speaking and listening, but you've informed us very clearly today that we're really dealing with complex and different levels and steps. So first we've indicated the language of understanding.
Has to have a language system.
A system and expressive as well as understanding. And second, you've indicated then even there's another step of dealing with such things as pronunciation and how the sounds one has, and that deals with, if there is a problem with speech therapy and development. And you've indicated there's a third area. And
then the third area is the area of hearing, and here again all of these many times can be very separate, and then also they can overlap, and because the child has one handicap, it very definitely will influence and go on into the other areas. And hearing is one of those areas. A child will not develop and does not develop then normal speech and language patterns if the child is a non-hearing youngster. And this can be to varying degrees, from a child who's very profoundly deaf to a individual who is minimally handicapped with hearing. But if a child, when he is born, is profoundly hard of hearing, truly is one of the most handicapped individuals, because it's very difficult for him to develop language. And being humans, that is the way we communicate. It's through a verbal language system.
I have something to come to mind from what you just said. Part of the problem under 3 could be a physical problem, as I understand, hearing problems at birth, or you acquire it early, or with a lot of noise that teenagers have and so forth, maybe develop it then. But is it also correct that in addition to a problem that may have to be treated with the experts, with a physical problem, are some youngsters in particular just not attentive? That is, they don't really have a physical problem, but they just don't listen, and you deal with that problem also.
Well, that's true with any of us. We do a lot of selective listening. We hear what we want to hear and not what we don't want to hear, and that is a part of it. And many times when we see youngsters, and this is very interesting, we can see nothing organically wrong with either a language handicapped individual, one who is mispronouncing and misusing sounds, or even a hearing handicapped child. You can see a very profoundly hearing handicapped individual who will have language to the level that you would think he'd be minimally handicapped, and then vice versa. A youngster who looks like he should have minimal language problems and has severe language problems. And it definitely deals with the individual. Each individual responds to either their own handicap or responds to their environment so differently that within the medical profession they have a term, and it's called the X factor, residual diathesis. And it's just an unknown factor that some people just respond, given who they are and what they're all about, to their handicap, and another one with a very minimal handicap will never really respond well.
Lola, when you're dealing with these 3 major areas that we're talking about, and you have a client, and there is a problem involved, this is a very simple question from my part with the lack of background in the field. When you are looking to identify that problem, does one assume that the problem always encompasses all 3 of these areas? Or oftentimes is it correct that a person may have developed their language skills, understanding, and even be expressive? They do not have an organic hearing problem, but that it will, for example, zero in on number 2, where there is maybe a problem of pronunciation, it may be lisping, it may be stuttering. Or does it always encompass all 3 of the problems?
No, you could, like each one can be identified as an individual disorder, or like I said many times, and it's interesting with a handicap, that many times when one thing starts to go wrong within the development and in the fetal period, a lot of things go wrong. And so it's not unusual at all when a child is born that he not only is going to have some brain damage, like say a youngster who's born mentally retarded, but that he'll have some other physical anomalies like a club foot, or be born without an arm. It seems like once something goes wrong, a lot of things start to go wrong. And so we're confronted with children that have many and have multiple handicaps. And then other times they're just isolated onto themselves. And that's where, getting back earlier when we were talking about how we identify these things and some of the history, it's very important when a child is born that they are attended to correctly and watched very closely, because the sooner and the earlier that we identify that an individual is, quote, going to have some kind of a problem and need remediation, the sooner that we get involved in with the parents and involved in that child's life, the easier it will be for them to adjust to the child's handicap, the easier it will be for the child to adjust to his handicap, and remediation can take place sooner. And that's why it's so critical, and I'd like to stress that with parents and teachers that are dealing with youngsters all the time. If they question it, do seek out a professional, do seek help, because so many times you can not only share with the parent, yes, indeed, this is a problem, but that isn't a problem, and let's get in and we'll really deal with this now, and this will come later. And I think it's a difficult thing many times for parents to also address the fact that they are going to have a handicapped child. So the sooner it's identified, the sooner professionals are called in and work is begun, the better chance the child has for a normal life.
I know our viewers are very aware of the fact that within 30 minutes we are touching the surface, and we will have to leave them without covering all these 3 major areas of language and speech. But I would like to be able to have your expertise used to identify some of the problems that they may already be aware of, but you can create a greater understanding for them. And I just want to put the footnote in that we're only covering a portion of the problem. I think what I'm about to ask would basically come under number 2, the speech therapy and development. If I put something in the wrong place, please correct me. But back to what I started with some time ago, some of the people that you certainly work with and we all see in life have some problems with the speech presentation to other people. And I want to go back to the example of lisping. I also want to cover stuttering. Am I correct that those 2 problems that we see most often do fall basically under the second area that we're discussing? And if I am correct, would you give us some examples of what this problem is and how people could try to classify that if that is exactly what we're talking about?
I'd like to do that, Tony, and in doing that, I'm going to kind of give a global overview, which will, I hopefully will then ease us into the problems and into the remediation. And that is, again, that when a youngster is born, it's very critical that he is neurologically and physiologically and psychologically intact. And if something is identified immediately that there is something going askew and not as a child should develop normally, the sooner, like I said, that we're called in, the better. Now I'll kind of give you some examples and quickly historically tell you a little bit about how language develops, how speech develops, and then the same way with hearing and the milestones that we look for, so that as we go into the disorders and the remediation, you'll have a little bit of a history what we're looking for that's right and what's wrong. A child's language develops basically if his hearing is intact. And a child begins to experiment with sounds within the very first few weeks of birth. More so, we're learning all the time than we ever even imagined. They're even beginning to think they do a lot of even actually making expressive sounds within the mother's womb now. But as a child begins to play around with these sounds and he's laying in the crib and a parent comes by and hears the gurgling and the cooing and the babbling, and they're always reinforcing and feeding in mama, dada, baby, without realizing the child will hit on the combination of dada or mama, and the adults in his environment will respond to that very positively. And it's very interesting how the child realizes every time I happen to put these 2 sounds together, I get a lot of attention. And so the child will begin to repeat that mama, dada, but it's a while before he actually makes the connection that dada is a person and that mama is a person. At first he's just making sounds and he realizes he gets a lot of attention. Well, as he begins to define that, and then as his own ability physiologically increases to make and produce more sophisticated sounds and words, and the environment is providing him a language system, the child begins to connect. Oh, dada, mama is a person. And by the time a child is about 1 year of age, he is producing a lot of single words. He has a lot of one-word responses, and he will be able to say baby, ball, doggy. And he has approximately about 25 words to 50 words in his language at that time, what we call language repertoire. He understands it, like I said to you earlier. He can point to it, and then he expresses it to you. This is a rule of, typically a rule of thumb in language is more sophisticated, but I'll give you a rule of thumb. When a child approaches about 2 years of age, he then begins to put 2 words together. Go bye-bye, see dada, want cookie. And these are very rudimentary responses, but many times when he says want cookie, he could actually be saying I want cookies and milk or juice. But this is his way of just saying want and then putting a word after it. When a child is around approximately 3 years of age, then he starts to say me go bye-bye, me want cookie, and he's putting 3 words together. When he's approaching 4 and 5, he begins again to be more sophisticated and his language increases, and he will switch to the personal pronoun I want to go bye-bye, I want a cookie, and then you see the adjectives starting to come in, the adverbs. He begins to make compound and complex sentences, and by the time a child is 6 years of age, which I've always found just really fascinating, he should have approximately 90% of his adult speech. And when you think about that, you can see how critical early education is, and that it's very necessary that we get a child in all these readiness stages, because no matter how much farther a person will pursue a professional, an education or professional field, he will add very few words to his vocabulary, and his language will become, minimally sophisticated beyond the age of 6.
That's most interesting. We are running short of time. We have only about 4 minutes, but from this global picture that you have given, some of the problems that arise that we've already been talking about, lisping, stuttering, pronunciation problems, are you saying to me that many times that comes out of that upbringing, and that we should be very cautious in how we deal with what we say to the child?
And I can plug in both the speech and the stuttering aspect very quickly. Along with this language developing, then the speech sounds come in, and the child produces the easiest sounds when he's younger, because his speech mechanism then is only able to produce sounds like P's and B's and M's and N's. Your more sophisticated sounds that take a lot more muscles and a lot more complex movements are your S sounds and your Z sounds, which are your lisp.
Right.
R's are very difficult to produce. So if a parent comes to me and their child's 3 and they said he cannot give and does not produce S's, we say, don't worry, that's not a problem. At 8, we'll look at it. Then also, at 4, a child has a huge explosion of language. And many times that's when parents come to us and say, my child is stuttering. And I think he's thinking faster than he can talk, and he repeats sounds. And this is when we identify stuttering. So these all kind of come together. The language develops, the speech sounds plug in, and at about 4, if we're going to see any stuttering behaviors, that's when we begin to see stuttering behaviors.
Lola, what causes this? Why does a child not develop these more difficult sounds, such as the S and the Z, and has the lisping problem? Or when they're having so much of their vocabulary being developed, they stutter, but later you calm down and you develop, and some people don't. Does your field tell us why that is happening to some individuals?
Nobody knows the causes of stuttering. It's an interesting subject, and the field of medicine has studied it, psychologists have studied it, our field has studied it. The encouraging thing, and I think the part we'll deal with in the next session, is we all fairly agree globally on how to treat it.
Okay. Even though we don't know what causes
we do know
of
how to
lisping
treat
or
it.
stuttering, the pronunciation problem, oftentimes we do know, do we not, that if one grows up in a certain environment or a certain family where that is the way words are pronounced, you pick it up by habit and by hearing, and that might be corrected much easier by simply having exposure to a different type of pronunciation.
Correct.
This has been fascinating, and I'm just sad that we did not have more time to cover in more detail, but you certainly have given a very clear view, I think, to the viewers of the field of language and speech therapy and the hearing. And I hope the viewers will be with us again next week when we'll interview you concerning what do we do in remediation, speech therapy. We're going to talk about some methods that parents could use or the professionals can use in dealing with that. And I thank you for being with us. It's been most informative.
Thank you.
Ladies and gentlemen, our guest has been Lola Hagedorn, who's an expert in speech pathology. And as I've indicated, she'll be with us again next week. Please have a good week. I am Tony Stewart.
The North Idaho College Public Forum can be seen at this same time each week over this station. This production was videotaped earlier by a North Idaho College student crew for viewing at this more appropriate time. Welcome to the campus of North Idaho College and today's broadcast of the North Idaho College Public Forum. The crew is comprised of North Idaho College television students. Your moderator is North Idaho College political scientist Tony Stewart.
Welcome back to part 2 of our discussion, in which we are identifying communication disorders, which include language, and secondly, speech development, and third, hearing. In order to continue this important discussion, I'm so happy to welcome back Lola Hagedorn, who holds a BA degree and also a master's in the field of speech pathology. Lola I've known for many years, and she's worked a long time in this field, and in fact, in addition to those degrees, she has worked on her doctorate in early education administration at the University of Idaho. Lola, it's a pleasure to welcome you back, and I have numerous questions, and we'll fight the clock again and see how much we can get done. Last time, as we closed the program, for those who were watching at that time, we had gone through what I thought was a most informative process of talking about the development of your field, which is a new field in relation to its specific developments, and we had talked with the viewers about identifying those communication disorders of language, the understanding, and then the expressive processes, and then speech development, and finally hearing. And I was so taken by your comments concerning the fact that when a child is born, or when all children are born, they have to go through a process to develop their language and their speech development, and how that relates to hearing. And you indicated that quite often we have to realize that there's both an organic problem that can arise,
right,
or it may not be an organic
right,
problem, and then there's the non-organic. And you indicated so clearly that as the child develops the first year, second, and so forth, they have common, what we might describe as problems, but are normal for their time. They may have lisping problems, they may stutter,
right,
they're grasping for vocabulary. But that when they reach a critical point, as around age 4, that some children, or the great majority I assume, go right on and develop normally and change, and that's no longer a normal accepted process to have trouble with pronouncing S's and Z's and so forth, or the stuttering. But other children do not go through the transformation to develop and continue through life to have those problems that you people work with. I know you indicated at the end of the show that in the area of non-organic identification, we're not sure why that some children continue the lisping problem or the stuttering. I wish you'd, before we start talking about remediation and therapy, elaborate a little bit more for us on what some of the people in your field have said concerning what goes wrong at this point.
Well, Tony, we didn't have as much time in the last program as we'd hoped for, and would like to begin this program clarifying a little bit that when you use the term organic or non-organic, we're relating to, if it's an organically related problem, we know from the beginning if a child is born, say for instance, cleft palate, if he's cerebral palsied, if he has a hearing handicap. And so then we're looking automatically for language problems, speech problems, and that is what we call an organic related problem. A non-organic related problem would be a youngster that we see, like you mentioned earlier, that is lisping and using S's and Z's incorrectly, but when we look at him very carefully and do an oral examination, the child physiologically is totally intact, that he has the muscle capability and the movement to produce S and Z, he's just not doing it. So that would be a non-organic related problem. We do not know the origin or the cause. So when we're looking at an individual in any of those areas, language, speech, even hearing and voice, we're looking to see, can we identify the cause, and if so, to what degree of severity is it, and then is it non-organically related, and we need to start right there and begin our remediation process.
Even though I think we made it clear to our viewers last time, I will emphasize once again that when a child is 2 or 3 and so forth, the parent may assume they have a problem and they don't. That's normal.
Right.
But later, as you've indicated, it's time to have concern and to deal with professionals. Let's talk about remediation as it relates to the second area of communication disorders, and that's speech development. I bring you a child that's reached the point to where he should be correcting this problem and is not. And the first problem is lisping. Now, you will take that individual and as a specialist, professional, you will work with the person. I'm aware that it depends on the severity of the problem, what you will do, but give our viewers some idea of what you might do with that child.
Okay, if we identify a child as having a lisp, and to the layman we're actually talking about the sounds of S, Z, could be SH, CH, and I'm going to give you the sound because we do not have it in Arabic, j, like orange, that we have a very systematic process in dealing with it, and we break it down to a very isolated situation. First of all, we have the child produce the sound all by itself. We take it totally out of all the other environment sounds and have him make the sound in isolation. As soon as we get a good sound from the youngster, then we add vowels with it. And as soon as he can produce a sound along with a vowel, then we will make it into very easy words. And we will start with a sound at the beginning of words, like a child can say sun better than he could say house. And then we take the sound and put it at the end of the word. And when he can produce that, and produce it very easily, and we'll practice that in practice sessions, then we take the sound and we put it in the middle of words. Because you can see how it progresses and gets more difficult, because now we've put sounds before it and sounds after it. So it's much more difficult to produce it. Then we begin into 2-word responses, 3-word responses, into sentences, and then we try to bring it out into his what we call running speech, into his conversational speech. And when the child gets to that level and it becomes habitual, then we will go on to another sound that is still out. And I'd like to explain this a little bit more clearly to you in the respect that, Tony, when we talk about sounds, we're actually talking about the sounds you hear. We're talking about phonetics, not the letters that people typically see. Like a Z sound many times is not actually the letter Z. And the same way with CH or SH. So we're really listening to sounds. We study the field of phonetics, and everything we do is by hearing. So it's the sound you hear and not the letter that you look at. So when we're talking about like sugar, the word sugar, we're not talking about S, we're talking about SH, sugar. Does that make sense?
Yes. Yeah.
So in other words, when we do an exam with a youngster, we strictly do a phonetic test and see what sounds the child is missing. And then that's how we begin to plug it in a systematic process. And we take each sound as they grow progressively. And we start with the sound that's the easiest for the child to produce. Say, for instance, he has an R out, an S out, an SH out, and an L out. We will take the sound that's the easiest for the child to produce, one that he's possibly not even making at all. He might be making the S sound, but only once in a while, but totally eliminating R. So we'll begin with the S because he already can produce it.
Yes.
And then we also look at how often that sound is used in speech. Like a V sound, is used very rarely in speech, and yet we know S is one of the most frequently used sound in our language. So we set up kind of a criteria that we look for when we do speech therapy. We do the easiest sound to produce, the sound that's already being used in the child's environment, and then the frequency that it is within our speech system. So we have a whole system of steps.
It appears to me that what you're doing too with that is that you're developing a confidence in the child. If it becomes easy to do a certain thing, then he or she's willing to try a more difficult one.
And at first they do not realize they're making the sound incorrectly. Teachers ask us this a lot, and it's really interesting. They said, it's so interesting because when he reads, will it influence his reading? Will he read incorrectly? The child himself thinks he's producing the sound. And it's not until you make him aware of it that he goes, oh. And then as she practices it and hears the new sound, and that becomes more habitual, the old one will actually become irritating to him, and he will begin to self-correct, and he will correct then out of a therapy session. And if his teacher and his parents and the people in his environment give him a lot of positive reinforcement, that sound is more likely to come faster and quicker. And that's why we like to spend as much time as we can with the other people within that child's life, the parent, the teacher, friends, and sisters and brothers. Many times I have people come to me and say, I'm very concerned about my child's speech. My own little sister did that just recently, and she said, Lola, I'm so very concerned about Paul Michael's speech because he's lisping and he's not producing R's. He's just now turned 5. And it's been really easy to say, that's not a problem. Just accept him, listen to him, enjoy him, and love him. Now, if he was 10 years old, I would say, yes, indeed, he needs therapy. And that's a nice thing for young parents to know.
Yes. Also, you've indicated to me that the older the person is that has this problem, the more difficult it is to correct, a 20-year-old, for example. That tends to indicate to me, and this is a wild stab at this problem, that if the person has been doing this a while, there's a conditioning process going on, and the longer the conditioning, the more difficult it is for them to both recognize that they're doing it and to correct it.
And the same way with stuttering, Tony, like we talked about earlier, and I think this is a very interesting thing too, and would like to spend a little time in discussing that in regard that here again I think parents and people, in trying to be very conscientious, trying to respond to the individual as best as they can, they make some errors that if they would be informed could turn that around and be a real benefit to that,
I'd appreciate that. The viewers are trying to help, I'm sure many of them, with someone that has a problem, and if you could give them some advice of how to deal with it without making it a more sensitive problem for the person, that would be helpful.
This is an interesting subject. Like I shared with you earlier, stuttering, we really do not know the cause. The medical field has researched it. Neurologists have looked at stuttering very closely. The field of psychology, our field. But it's one that we do pretty much agree on is in regard to therapy. But almost all youngsters have disfluencies between the ages of 4 and 6. Now, like you said, most of them, the majority of them, will outgrow it, and it will drop out as soon as it occurs. And people have a lot of preconceived notions. Many times when a parent will come to us with a youngster stuttering, they'll say, I know exactly when it happened. And it's usually a traumatic situation. But as we share with the parent that, no, that indeed is not it. The behavior is there. We've identified it. Now, these are the kinds of things that you can do at home. And we ask them to share this information with anybody that comes in contact with a child, the parents, the grandparents, so that they are all listening to the child and responding all in the same way as consistently as possible. And many times, and this is true with all of us, if someone calls attention to a behavior that you have or a habit that you have, the more they call your attention to it, the worse it gets.
It magnifies it.
And typically when I talk about stuttering, it's funny, I stutter. And it's so interesting, I've had people say, well, you stutter when you're talking about stuttering. Well, you become so aware then of your own speech that your own speech begins to break down. And another thing that we know about stuttering or speech in itself is the very fact that the more anxiety a youngster feels, the more stress, the more pressure, the first place you see it begin, to break down in the child's behavior is his speech and his language. The father will see a child stutter or have problems more likely than the mother because the child is very fatigued at the end of the day. So we share that with parents. If you do see it be worse at night, that's okay. Don't worry about that. We expect that kind of thing to happen. Stuttering is very cyclical. People will go many times, many months and not stutter. We also know that it occurs more in males than in females. 8 out of 10 stutters are male youngsters. People can sing and not stutter. I know people will say to me many times, well, he never stutters when he sings, or he never stutters when he's in a choral reading group. Many times actors are stutterers. Steve McQueen was a stutterer, Jack Parr was a stutterer, George Burns is. But when they assume a different character and they're no longer themselves, they don't stutter. And yet when they're themselves, they do. These are kind of the things we don't know why. We have no idea why this occurs. Stutters will tell us that when they're in rooms by themselves, they never stutter. Or if they're talking to their pet, they never have any stuttering behavior at all. They also learn different little habits that actually what we in our field call the stuttering. A layman many times feels that stuttering is just repetition of words or phrases or sounds. But that's actually what we really observe in little youngsters that are 4 to 6 years of age. The easy repetitions of words like and, or baby. But that is in its very most elementary stages. And that's when we say to parents, these are the kinds of things you can do, and I'll share a few of those with you.
Please
and the
do.
same if you have any stutterers now within your own life. These are still things that you can do that will help that particular individual. One thing is never tell the individual to stop and start over. Let them struggle through the word. And many times the struggle behavior is so difficult as a listener. It is very difficult to listen. Another thing is don't say to the youngster you're talking faster than you can think. Never give them the word. Never give the word to the individual. Do not teach him to substitute one word for another word. Some of the real positive things that people can do is to keep very good eye contact with an individual that is stuttering. And I try to share with the people I work, don't stare at the individual. But on the other hand, many times people feel in order to help and make listening easier and make the stutterer more at ease to look away from the stutterer. Well, actually you're signaling that's not very pleasant to me. So to keep very good eye contact with the individual. Another thing with a stutterer, listen to what they say, not how they say it. That is so important. And even with a child that has some speech difficulties, if they mispronounce sounds, don't tune into that. Tune into what did that individual say to me. So if an individual comes up and says, I want a drink of water, respond to, I want a drink of water, and not to all the disfluencies and the pushing and the struggling. That is when we become concerned, is when a person begins to push words out and struggle with words. And many times they begin to develop, like I shared with you earlier, secondary symptoms, and this is what we're really looking for. And this is when we begin more direct therapeutic programs. Many times a parent will say to a child, take a deep breath, and the child will hit a word he's having difficulty with, and he'll take a deep breath and the word will come out. Well, that will work for a while, but shortly after that, that doesn't work, and he'll take another deep breath. And after a period of time, his struggling behavior and his stuttering is actually all the deep breaths he is taking. So if we see an individual in middle grade school or adulthood, we realize at that time, and we deal with it a lot like alcoholism, we say we can never truly correct it so that you have fluent speech, but we want to arrest it at this point. We want it to not get any worse than it is. We want to eliminate some of these secondary behaviors, and then we want the individual to know and be comfortable with that, yes, indeed, he will probably always have stuttering behavior, that it's never going to be totally eliminated, but we want to have him be comfortable with it, deal with it, be open and honest about it, and develop other areas that he can feel very confident in himself and comfortable with his personedness.
As a humanistic person, one would need to do that even if the language never improved as we perceive it, because that person has feelings, and I'm sure they're very hurt oftentimes by other people's reaction who are innocent but are not handling it properly. I think you've been very helpful to the viewers.
Do you know, one thing I wanted to share with you, Tony, and this is in regard to not only my field, but I have found, because we've worked with all aspects of handicapped youngsters and individuals, that honesty is by far the best policy. And that if you're not honest with the child, they know that. And when you work with individuals, they know when you're not honest. And we've told teachers before when they say to us, what do I say when other youngsters come up and say, he sure does talk funny? And we've shared with them, yes, you need to say he does have difficulty talking, but it takes a long time to learn how to talk, and he's working on it, and I accept him. And the child typically will accept his own speech, and then the children in his environment, they just accept him like that. And before long, they're playing again, and the teacher overreacts to the situation, and truly, when you're honest, and it's out in the open, then everybody goes about their business.
Very excellent advice. In the field of language, we have a number of problems. Some of them are not severe, and some of them are. I would like to mention three and then get your response.
Okay.
In the area of language, some problems are just poor training, I suspect, grammatical errors. We have problems with the tenses, or we become repetitious, and in all due respect, there has been a trend in recent years to be very repetitious with such things as you know, and those kind of things. But we also have a second problem of preschool children that have brain damage and so forth, and the language problems that comes from that. And then finally, in the older population, such physical disabilities as strokes. And if you have time and would be willing to do so, let's take one of those at a time and indicate what one can do in the field of language with that.
Okay, I'm going to start at the end with that, Tony, because here again, I think there are very few people that will not have a grandparent, a parent, even possibly a child or a sister or brother that will not suffer some type of brain trauma or brain damage that will involve retraining of language. And I'd also like to make a correction when I talk about remediation. In order to remediate something, it has to have already been there to remediate it. So many times we really truly do not remediate, we mediate. We start and correct it, and then if the language has been intact and it's lost, we remediate. And that would be an individual who has had hearing, suffered a trauma, and no longer has hearing. So we want to retrain their hearing processes. Same way with language. It could happen to you or I today. Our language is totally intact, and we could walk outside and be hit by a car and be a language handicapped individual because of the brain damage that we would have received. And so I think it's important that people realize some of the things that we see in individuals that have had brain damage, because some of them relate to language and a lot of them also relate to psychological responses. And it's very traumatizing to families to have a sweet little grandma who has never swore before in her whole life to suffer in a massive stroke and all of a sudden use very, very foul language very easily and very freely. And they do not know how to react because this lady has never had that language before. Well, we have learned again through our history of these young men coming back from World War II that have had and had experienced in this language trauma, that they're very emotional and they respond very easily to tears. They cry very easily. They're very sensitive. They cannot control their emotions. A lot of words come out that they have no control over, and that would be like the swearing behavior. People think they understand more language than they actually do because they've learned a lot of the social graces, like with you now responding to me, smiling and nodding. I'm perceiving you're understanding me. This is what a trauma individual will do many times, smile and nod, and the family will say to me, he understands what we say. But when you really do a diagnostic examination, you realize that he isn't understanding what you're saying at all. So we also then have to begin to test that and build up his receptive language and then again work on his expressive language. But I think it's important that anytime you have a youngster or an individual in your life that has suffered any kind of an accident or trauma and stroke, that you immediately contact a speech pathologist, because they can not only help you in how to deal with the person with their speech and language, but also what kinds of things do you want to expect from that individual within your home. We learned in our profession a very interesting thing, which gets back to some things I'll plug into with speech sounds and language. We had a very renowned professor within our field suffer from a stroke. And he was in his office at the university at the time it started to occur. And he started to write and record what was happening to him. And we have a very clear, which is interesting, picture of what was happening to this man as the stroke began to happen. But the interesting thing afterwards, because he was one of the leaders in our field of communication disorders, and he was in a university setting, and all of his students and all of his colleagues around him were so anxious, of course, to provide the very, very utmost of remediation, that he said that people would come into the room with him and see he was unable to express himself. He was unable to say to him, no, 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 this isn't right. They were trying again to get him, to test him to what he knew and what he didn't know, and they were trying to give him words that were totally inappropriate in his environment. And actually the only thing he wanted to be able to communicate was either verbally or through gestures or some kind of a sign, I need to go to the bathroom. And through all our sophistication and all our eagerness so many times to make, quote, the person normal again, we forget some of our most primary needs, and that's what it all is about, making our needs known to another individual so we can respond. So since that has happened, we look very carefully, what are the needs in that person's environment? What language needs does he have? And you're not going to take an individual who does not need a sophisticated language system and try to plug that in after a trauma. You need, what does he need when he goes home? What kind of language does he need when he goes back to his job? And so we really need to look very carefully at individual needs, no matter what the disorder is, the communication disorder.
If that disorder is the one that we're speaking of, where there's been some kind of brain damage, that be a stroke or an accident will be varying depending upon the severity of the accident or the stroke.
Right.
And so where you start with the individual or what their needs or interests are will
on their
vary.
Strengths and on their weaknesses, and we always want to build on their weaknesses and bring them up more to strengths, but we also want to, and I wanted to point this out globally again with all the youngsters and individuals that we work with, always look at their strengths. Even with normal youngsters, we always share with parents, look at your child's strengths. We're so tuned in to looking at people's weaknesses. Look at their strengths and really reinforce that. Let us as a professional start to plug in this problem and this one, and we'll build it up. But you at home can reinforce all the things that they do well.
Yes. And I know our viewers are interested to know that as you told us about the lisping and so forth, which is another treatment, that you will work with this individual and your skills of communicating, and it may deal with building on certain words or some pronunciation. In other cases, it may be past that and you're already developing certain sentences. I may be off track on this next one. Correct me if I'm wrong. I'm also interested in the question of grammatical sentence structure and all of those things. Do you deal with that at all, or is that left solely to the English people and academics?
In fact, that brings me to a two-pronged answer on that. No, that definitely is a language disorder, and we deal with that just like we deal with your speech sounds. We look at language and we begin to plug in nouns, and like I told you earlier, a child will first say me go, me want. That is a very elementary form of language. As he becomes more sophisticated, he uses the personal pronoun I. The same way with his verbing. He begins more sophisticated verbing. He begins to conjugate his verbs, and he begins to use adverbs. And so we definitely look at sentence structure. That is a part of our field. And we, all of this is done in a very orderly, predictable manner. When we see when an individual comes in, we do not attack the total problem. We start way down here, and we start to build, and we start to build, and it's very slow sometimes, and it takes many, many, many years just to get even a speech sound out of what we call an aphasic person, and that is a language individual that I shared with you earlier, that had a stroke, has suffered some kind of a trauma, they had language, and now they're without language. That is what we call an aphasic. The same way earlier when I talked to you with cleft palate youngsters, we have cleft palate youngsters that have very normal speech. And we have children, like I shared with you earlier, that look like you and I physiologically and physically. They look wonderful, and they have absolutely abominable speech. So we deal with all these different levels and degrees, but grammatical errors are within our field. Any kind of communication, it's even writing, reading, the grammatical aspect of it, that is all language.
It's very expansive. We have only about 30 seconds, and I just wanted you to share with the viewers that when a person comes in under certain conditions, that there are a lot of people who work with individuals. Could you just quickly run over the people that would be involved?
And we've learned this over the years too, and it's very important when children and individuals have problems. Anymore we team look at them. And my field, the field of communication disorders, psychologists, psychiatrists, physicians, educators, and even many times we'll call in other members of the family, all look at the youngster and all agree on who's going to do what and communicate back and see how they're coming.
I'm so sorry we're out of time. It's been so informative. Thank you, Lola, for being here.
Thank you.
Appreciate it. Our guest has been Lola Hagedorn, dealing with the whole field of communication disorders. I hope you've enjoyed this 2 weeks and that you'll be with us again next week. Please have a good week. I am Tony Stewart.
The North Idaho College Public Forum can be seen at this same time each week over this station. This production was videotaped earlier by a North Idaho College student crew for viewing at this more appropriate time.